This is a project that sort of started off as more of a health-specific project, but you'll see as sort of somewhat inadvertently, but I think interestingly, moved into telling us something very striking and interesting about microfinance in general. So there's been this idea out there that microfinance organizations have sort of spread throughout many sections of sort of poorer countries to sort of service a lot of clients. And these MFIs have grown to be thought to be potentially very well suited to distribute any number of different sort of financial services, and insurance being a prominent one of those. So worldwide, many poor households lack formal health insurance, and there's been this idea that because MFIs essentially have this fixed client base that's presumably getting sort of substantial welfare from that relationship with the microfinance organization, you might be able to sort of bundle things into that relationship and essentially kind of keep people in a relatively unselected client base, much like how in the US sort of health insurance gets bundled in with jobs. You're not going to leave your job just because you're healthy and you don't want this health insurance. And so the idea has been that there's this presumption of these large welfare gains that might be used to sort of broadly provide services through MFIs. However, and this is sort of a slight tangent for the moment, even in settings where sort of the estimated marginal returns to microfinance are often fairly large, we know from a variety of different studies that sort of coming out recently that MFI loan take-up is still often quite low. And these businesses don't expand. These businesses often shut down. And so while at the same time, businesses seem to have on paper these large sort of financial profits, they don't act always like they're businesses that are generating large financial profits. And so there's this general question floating out there that different papers have sort of provided pieces of, but it's this nagging question in our minds of, are there actually large welfare gains to microfinance? And so it's going to be something that we're going to look at essentially in this paper. So SKS Microfinance started introducing this mandatory health insurance policy for its clients. So in December 2006, it decided that it wanted to do this, and it partnered with an insurance organization. It basically made as a mandatory requirement for renewing a microfinance loan into sort of the next iteration, purchasing this catastrophic health insurance policy that would cover hospitalization and maternity. And regardless of sort of what the policy was and what it did, one of its main features was that it was sort of relatively cheap. It was about 500 rupees, which is about sort of $10 now, about $13 at the time. And SKS was sort of interested in rolling this out in sort of a variety of different places, and they gave us a list of 201 villages where they might do this. We selected 101 of them randomly to receive the product, and 100 of them were sort of kept out as sort of a randomly selected control group. And so the initial finding, which is very consistent with sort of anecdotal accounts at the time, was that this product, despite being fairly cheap, was extremely unpopular. Right? People didn't want to have to purchase this insurance policy, and indeed you see in the data that loan renewal declined pretty substantially.
But it's 527 rupees per year?
Per year. So it's a 520, the insurance policy sort of lasts for a year, and the annual premium is 525 rupees. In contrast to sort of the typical loan, which is about 8,000 rupees at the time. So you can think of it as essentially like if insurance itself has sort of no value, it's about a 6 percentage point increase in the interest rate, which is on top of about a 24 percentage point interest rate at the time. So what happened was loan renewal declined greatly. So it declined by about 22 percentage points, or about 31% of the sort of baseline loan renewal rate. And we showed in this previous paper, this sort of short paper in Papers and Proceedings, that shows that there wasn't adverse selection in the sense that this decline in loan renewal wasn't systematically people sorting in and out based on sort of proxies for sort of how much they might want insurance. Basically just because nobody wanted insurance. Even people who might potentially have a need for insurance, people you would predict would have a baby, people you would predict might have sort of catastrophic health events, nobody actually wanted the insurance. But what happened was some people still remained in just because they had some value for microfinance. But the fact is that a lot of people, and this is our intuition, a lot of people didn't value microfinance enough that it was worth paying this 525 rupee fee just to sort of keep it. Now, we sort of show initially, very quickly, that all of this sort of had little actual direct impact on health and healthcare, because it turns out that people were fairly right. in not wanting the insurance, and that the insurance itself, through various administrative failures on the part of the organizations, turned out to be basically useless, right? People couldn't use the insurance. It sort of effectively wasn't useful at all, and we'll show that sort of health and healthcare financing wasn't affected at all by this policy. But what did happen was sort of client businesses declined pretty substantially in places where they were forced to purchase this insurance policy because of the decline in loan renewal. And so we show that essentially in this reverse experiment on microfinance, there are these sort of substantial declines in client businesses, which people have sort of found in other contexts where there are these large gains to businesses when people get access to microfinance. So there's sort of the reverse experiment here, which is sort of coupled with this sort of price sensitivity. And if you essentially put these two together in a way that hasn't been brought together before in a paper, it implies that these financial impacts on businesses are actually largely illusory, right? So people are getting this sort of, there's this large impact on firms' profits on paper, but that doesn't actually translate into welfare. Because if you sort of take people's behaviors at face value, it wasn't worth sort of 525 rupees to them to sort of keep what might effectively be almost 20,000 rupees of sort of on-paper profit. Yeah.
So how does this 525 compare to the amount that they pay in interest over the course of the loan?
Right, yeah, so that was the point about the 525 rupee fee compared to about an 8,000 rupee loan at the time. You could think about it being effectively sort of a 6 percentage point increase in the interest rate on the top of a base of about 24 percentage points in interest rate. So it was an increase in the interest rate you could think of in percentage terms of about 25%. But the key number to really compare is essentially what is the impact on business profits against what is the premium. And this impact on profits is hugely larger than the impact on the premium. Yeah.
But this seems like a very strong conclusion to this. I mean, isn't another theory to just sort of say, gee, guys are a bit myopic or don't know what their returns are going to be, or a bit myopic in making their decisions, and that would explain both overvaluing the cost and the fact that they have these massive returns to begin with. Because if they knew they had massive returns to begin with, why aren't they investing? It sort of seems like.
Well, the way that I interpret that is that right. So you can take one view of the world, which is that people are acting in their interest. They kind of understand what's going on. They sort of understand their lives better, than we understand it looking at data, many thousands of miles away. So you can take that view, which is that sort of people are acting in their self-interest, and take that at face value. And that's why I did put an if statement on it, which is sort of if you take these people's decisions at face value, this has a strong conclusion that the microfinance gains don't actually translate into sort of welfare gains. Now, the other main potential hypothesis is that people have no idea really what they're doing and their actions aren't really connected to reality in any meaningful way, in which case we don't know. In which case we can't learn about their actual behavior. We can't learn about their actual economic situation from their behavior, and that's true.
I guess the other point was that the fact that certain people have very high returns when microfinance comes in, and it would have been profitable given their alternative loan at a very high interest rate. So probably some people were leaving money on the table from the money lender when they had the option of getting from the money lender. So clearly not everybody.
That's an important point in the sense that this is for a particular complier population, which is sort of for the compliers, for this 22 percentage points of people who dropped out. For them, there were very minimal welfare gains from the financial impacts that were sort of measured. Now, that doesn't mean that everybody gets no welfare gains from microfinance, because some people still stayed in. And so presumably their gains from microfinance are greater than the 525 rupees. It's just for this complier population, which is about a quarter to a third of the actual borrowers from microfinance, for those people, this 525 rupees actually serves almost as an upper bound on their valuation of the microfinance in total.
I think the point is that the other results of big impacts also are an existence proof that some people don't know that their returns to microfinance.
Or I guess Rick would argue that they're positive returns and low welfare benefits. I think it's sort of a tautology. I don't think we can. I think.
And I think that's
right. They might think they're right.
And that was even one of the original motivating features. And I think when you look at the data with this worldview, there have been a lot of hints at this before. And exactly one of those hints is that on the one hand, people measure these large gains to microfinance. And on the other hand, this paper in Baracco, I believe, right? They measure gains to profits in microfinance of 130% or something, gains on profits. But when they offer people microfinance, only 13% of people take it up. Right, and so on the one hand, there are hints in other papers and other data where it's like, while the gains are very large, a lot of people seem to not want to pick up these dollar bills on the ground, right? And that's a puzzle that we need to try to reconcile, which is like, if it is true that these gains are so large, why aren't people taking them? And the simplest explanation is simply that they're not taking them because those gains actually aren't that large from a welfare point of view. Because it's not just sort of what you measure in terms of profits, they're also unobserved entrepreneurial costs of labor. There's an opportunity cost to their time. There's a lot of hassle involved in doing this. There are a lot of potential costs associated with doing these types of things.
And asymmetry between not taking up, you could say, well, they don't know, but here they are running those businesses, so it would be a bit hard not to know anything about it.
And there's one advantage of the reverse experiment, which is that, yeah, in a sense, the knowledge barrier is presumably lower for people that are sort of doing it already and sort of going to not doing it versus the people who, yeah, might not just know that there are these large gains. All right, so what was going on in the program? A bit of background information. So this program the insurance became mandatory for renewing clients or new clients. I've talked about there was a 6 percentage point increase in the interest rate. They could basically get, this is going to be useful for interpreting the data coming up shortly, they could get sort of benefits from the insurance in two ways. They could sort of, for in-network providers, they could presumably go get sort of cashless treatment. And for out-of-network providers, they could sort of go get the treatment and then submit reimbursement claims that would be reimbursed. So there's sort of two different types of ways you could use the insurance. It was randomized at the village level to sort of deal with spillovers. I sort of talked about this. Okay, briefly on this sort of data construction. So there's a baseline survey where we collected sort of basic information on households and adults in the households, sort of on health status, healthcare, financing, basic economic variables like consumption and income, business outcomes in particular, and sort of social outcomes. And I've grouped it into these four categories: consumption, income, business, and social outcomes. Because one of the concerns about trying to evaluate something as large as microfinance is that there are a lot of different potential outcome variables you can look at. And so drawing on sort of recent work that's been done, sort of a series of papers on microfinance, to try to prevent sort of specification searching type considerations, we can sort of group things by these different families of outcomes and sort of look at those in the same way that other papers have looked at these. Then we did an end-line survey, which is going to be the primary focus of the data today, which with a relatively small attrition between baseline and end-line. And then also crucial for the analysis today is we got administrative data from SKS on sort of clients' actual renewals and on sort of insurance enrollment and insurance claims that were submitted and processed and paid out. So we can both use self-reported data on the part of clients and also administrative data that sort of is presumably tracking these people's experiences. And then we collected this additional data on sort of major health events that took place on a more rolling basis, where we sort of specifically went to centers and asked people, have there been any major health events sort of that in your household? And then for those people that reported there being a major health event, we sort of followed up with them and gave them a specific survey about what happened there, to essentially try to oversample these rarer health events that might not show up very much in the baseline and end-line samples. And that's going to be useful to sort of track and verify the lack of sort of actual insurance usage and the lack of sort of a direct impact on health. All right, so here's quickly the baseline sample. I'm going to largely skip this aside from just showing this sort of balance between treatment and control. The main regressions we're going to estimate, there's nothing really fancy going on here. We're going to look at outcomes, regressing it on whether you're in a treatment village or a control village, controlling for randomization strata. So we stratified by SKS branch and by sort of size of the client base to ensure sort of similar number of treatment and control observations, but we're just going to include those fixed effects. We cluster the standard errors at the village level, and we're going to take some care to deal with sort of multiple hypothesis testing, both by grouping things by sort of family of outcome and also adjusting the p-values for multiple hypothesis testing across these different families of outcomes. Then just one small point on the magnitudes. This is sort of similar to what John Gruber was saying earlier. In a sense, we're looking at sort of a post-treatment period we're looking at sort of a treatment period relative to the control group. Not everybody in the treatment period was treated at all points in time because through administrative constraints, SKS had to roll out the treatment over some number of months. And because that rollout was non-random, we sort of focused mainly on intent to treat estimates based on sort of when the treatment sort of began. But because not everybody was treated, for sort of some of our initial regressions, you can imagine scaling some of the magnitudes by a factor of about 1.4 based on the fraction of observations that would have actually been treated at that time. Okay, so the first sort of result on sort of loan renewal, this is using SKS's administrative data, and this is about loan renewal in that sort of first year after treatment is introduced. So we have a sample of clients who had loans outstanding, and they basically come up for loan renewal in the first year after sort of treatment, after the treatment started, and then we estimate whether they renewed that loan or not. And you see loan renewal declined by about 22 percentage points in treatment areas relative to control areas. Now, if you look at the time of the end-line survey, which is even after the health insurance requirement itself has been eliminated and people are no longer even required to purchase health insurance, still loan renewal is lower by about 16 percentage points. Right? So once people left, they didn't even come back after they could have without even purchasing the insurance policy. Right? So again, this is some evidence consistent with some relative, we can get back to this in the interpretation section. But then if you use the self-reported data, you see sort of a smaller effect, which is fairly consistent with sort of measurement error, but still sort of a substantial decline in loan renewal. And then if you ask people about whether or not they have a loan from another MFI, they very rarely report compensating for the loss in loan with SKS with moving into a loan from another MFI. And a lot of the villages we're looking at, there weren't very many other sort of potential sources of microfinance loans. Yeah.
How does this compare to other bundled products that microfinance organizations provide? Obviously, you're comparing it to the control group, but is there any other study which finds that if MFIs try to bundle products, the loan renewal comes down?
I don't know of another study that's looked at that. MFIs have thought about this, but I don't know of a study that looks at that.
Is there something particular about health insurance, or it's more about some bundling products that you're seeing here?
Yeah, so I don't know. It seems like a good opportunity for replication. To see whether, paying 525 rupees for health insurance, whether that people treat that differently as paying 525 rupees for, a stuffed animal or something. Yeah.
So another way, let me go in further, this is like another way of thinking about the welfare of this would be to sort of estimate, so you can estimate, so this just estimates elasticity, right? And if we're doing back the envelope calculation, you get an elasticity about 1. Right, 25% increase in the price of load, 25% decline in take-up.
Yeah.
It's about 1, right? So, but then you could estimate sort of a, isoelastic demand curve and sort of draw that thing of 1 kind of all the way up and calculate kind of the implied welfare of the loans. And can you compare that to kind of the profits? Is another way of getting at.
Yeah. So you're saying actually just estimate people's demand curve. I mean, we're doing that. The question is sort of like,
Maybe another kind of like, price theory approach. You're sort of saying, let me take a really hard line on people actually understand the welfare consequences of this.
Yeah.
So I'm saying, well, another way to do that would be from sort of to estimate the area under the demand curve as a measure of kind of consumer triples in the loan to compare that to your estimated profit.
Yeah, and I mean that's effectively what's going on. It's just we're looking at sort of 2 points in the demand curve, and we're going to compare that to sort of the impact on their profits. What we're going to get is going to be an answer that's relevant for the complier population. Now, if we wanted to take seriously extending this to sort of the non-complier population, then you would try to basically, you would then want to look at sort of, well, given these 2 points on a demand curve, can you try to learn about the demand curve everywhere else? And sure, I mean, with 2 points, you could try to extract, I mean, you could fit a curve, you could fit a line, you could fit, different stuff. But yeah, I think it's so striking just from the complier population that we're just putting that out there first, rather than sort of trying to then say, well, this is also true based on some assumption about the elasticity of demand. This would also be true for this fraction of the client base or something like that. I mean, that would just be very functional form dependent, but I mean, we could go that direction. All right, so that was for the full sample. If we restrict it to the sample that are sort of baseline, that are business owners in the end-line survey, you see fairly similar magnitudes. And you see also decreases in sort of total loan amounts. This is not conditional on having a loan. So this is mainly driven by just the extensive margin of people losing loans. All right, so what we see here now, this is going to be a sort of a slightly depressing diversion, which is that the health insurance itself had basically near zero usefulness. All right, so when you ask people using this major health event survey, on these 25,000 major health events that we sort of surveyed people on, this is sort of by event, about half of them say at the time that that event happened, the person who was affected by the event did indeed have insurance. Only about 30 people report receiving insurance benefits. All right? So I mean, this is a statistically significant effect, which could be just measurement error because we're asking for these additional 50 percentage points of people to circle one of two circles, and they might have just inadvertently circled the yes, I used insurance circle. But about 30 people report receiving insurance benefits, which is sort of roughly evenly divided between maybe 15 used a cashless facility and 15 received reimbursement. Now, some of this might be due to the fact that we surveyed them relatively shortly after the event actually happened. And so potentially more encouraging is that 5% of them report that they expect to receive insurance for that event. Now, that might be overly optimistic because the claims were processed pretty poorly. But 5% do expect to receive reimbursement. Now, if we move forward a little bit on that, we can group things up to the client level. And this is for clients. About 70% of them ever report in our data experiencing an event at which point they had insurance. And about 1% or half a percent sort of report ever receiving any insurance benefits for any of the major health events that we surveyed them on. But 10% do report that they expect to receive insurance at some point in time, which is still very small because these are just conditional on sort of having these major health events. And then we sort of move to the administrative data, where we ask sort of for each client, using the administrative data, does it indicate that they actually were enrolled in insurance at the time? And most of them were enrolled in insurance at the time. And only about 7% of the clients at any point received a benefit from the insurance. 2.5 percentage points of them used a cashless facility, 5 percentage points of them indeed received reimbursement. So some of the expected reimbursement did translate into reimbursement. So a lot of the expected reimbursement didn't translate into reimbursement. All right? So there are stars, but the magnitudes are sort of very small. And what we show here in table 4 is that there's effectively no impact on actual health care or what people did after these events as a consequence of presumably having insurance. So they're not more likely to stay overnight in a hospital. They don't spend more or less on the health event. They don't change like where they borrowed money from for paying for the event. This is for the major health events. And then if we look in the end line survey, there's no differences between the treatment and control at the end line in terms of what happened after they experienced sort of major health events or the number of health events that they experienced, their sort of overall health status in terms of their ability to perform daily activities. There's no impact on their overall life satisfaction, which you can come back to because that's sort of a general, somewhat related to welfare question. So these people are earning much lower profits, we're going to see, but they're not less satisfied with life. But they do report, and the one sort of substantial thing is they report substantially lower self-reported health, which is actually kind of consistent with some other work that just shows we probably just made health very salient for these people by enrolling them in insurance and trying to teach them about insurance. And they've been more attuned to the fact that they have lots of health problems, which you see in all of the data, that these people are fairly unhealthy. And they're more aware of that now. All right. So what do you actually see in terms of business outcomes? There's very little impact on whether or not these people owned a business. So on the extensive margin of sort of business ownership or not, there's not a differential effect of losing access to microfinance. There is a lot of churn in who owns businesses. And so in panel A, we're going to focus to start on all of those people who own businesses at the baseline, many of which don't own a business, most of which don't own a business or don't report owning a business at end line. But we're going to focus on everyone to start and just put in zeros for everybody who doesn't own a business at the end line. But if you look across the different outcomes, they're spending less on assets, less on workers. They have lower total sales, lower total profits. Individually, they aren't statistically significant. But if you create sort of an index across these following sort of standard practice in this microfinance literature, you see a marginally statistically significant decline in the sort of index of different outcomes. Though if you were to pool this across the different families of outcomes that we'll show you, it wouldn't be statistically significant. But this is sort of, everything is dampened by the sort of large number of zeros from sort of the 70% of observations we're putting in zeros for. If you limit the sample to people who had a business at baseline and at end line, now you see substantial and statistically significant declines in these ranges of business outcomes, overall total profits, and the business index. And if you further expand the sample to just be the business owners at end line, you see the substantial declines in business outcomes. And just to note, you don't see any impact on whether someone at end line owns a business or not. So it seems like the businesses themselves are declining substantially. There was very little impact on health. If you think about what happened to sort of annual consumption, there's basically very little impact of losing access to microfinance on sort of total consumption or consumption across various sort of subcategories. There's some evidence for a decline in durable consumption and marginally an increase in temptation goods, which is for those invested in the sort of microfinance literature, it's somewhat the reverse of the microfinance literature, and that people tend to find that microfinance raises durable goods consumption, reduces temptation goods consumption, but those aren't statistically significant in our setting. Basically, just there's no impact on consumption. So despite the fact that profits have gone down a huge amount, there's no impact on consumption. There's not an income in general on sort of overall income across different sort of categories. And there's no impact systematically on sort of social outcomes, things like your kid's education. There is an impact on sort of this index that we formed of sort of teenage girls' attitudes, sort of like socially progressive responses to questions. So questions like, should men eat first? Should men be more educated than women? Things like that, sort of coded such that sort of more socially progressive attitudes are more positive. There's sort of there's a turn toward conservatism as people lose access to microfinance. It's there in the data. You can make of it what you will. But if you pool across all of these things, there's no impact on these sort of social outcomes. All right, so just kind of bringing it together. There's something just very striking, which is that these places lost access to microfinance, and their businesses were greatly impacted. And now if you sort of think about the estimates in Table 2 on sort of loan renewal as essentially a first stage, that some people lost access to microfinance, and then you think of the impacts in Table 6, the sort of business outcome table, as the reduced form of sort of how much profits overall declined in those villages, the implied impact on the people who actually lost access to microfinance is about 20,000 rupees a year decrease in business profits. Right? That's assuming that sort of there's no direct impact on people from just offering them this insurance. And they were unwilling to pay 525 rupees to keep that 20,000 rupees in profit.
Sorry, which is the 20,000 for those people who had a business at Headline, or is it for everyone?
This is for the people who had a business at Endline. So this is essentially dividing this, you can't see my finger. This is dividing this 5,430 rupees by 0.26, essentially. All right, so the implied impact on sort of business owners themselves is about 20,000 rupees. They weren't willing to pay 525 rupees to maintain their loan. All right, and so the caveat here is that this is for the complier sample. There might be some people, and there in fact were some people who are willing to pay 525 rupees to keep their 20,000 rupees in profit or more in profit. But still, that's not a great consolation, right? Like there are a substantial number of borrowers for whom the financial impact was quite large, but they seem not to care about it. And now there are two main possible explanations for that. One is that they have no idea what they're doing. And the other is that they know what they're doing, and this 20,000 rupees in profit is not actually worth 525 rupees to them. Yeah, basically.
So there's an accounting problem here because their consumption doesn't go down, but they have 20,000 less. So is it that they are saving less or
yeah, so the idea is that, I mean, a lot of this is not measured, and that's sort of inherent to the problem, which is that there's a lot of things that aren't measured. But for instance, like daily labor, hired labor, spot labor type things, like the fact that consumption is not going down is exactly consistent with the idea that there's not much of a welfare impact because they're losing that profit, but they're managing to get that income from some other source. Because now that they're no longer running their business at that level of scale, they're doing something else such that their consumption is not actually going down. And that's true even if you restrict the sample to business owners. The business owner's consumption is not declining, even though their reported profits from their business are declining by 20,000 rupees.
But that is your issue, like not profit is not welfare, but like we're not measuring profit.
Yeah, exactly.
Right, so our measure of profit is not welfare, right? And like the measure of profit that people typically measure is what?
You did a bad job. You should have looked at total income of the household.
We did look at total income of the household. Total income of the household was not affected. These people lost access to microfinance, and their businesses were substantially harmed, but sort of total income across sort of different stuff was not substantially affected. So as we sort of talking about the measurement issue itself, so there are a couple of different ways. There are two main ways you can sort of measure profit. You can ask for sales, and you can ask for sort of all the expenses, and try to just subtract one set from the other. Our measure of profit specifically that we use is we just asked households directly a number of questions about their business, one of which was sort of like, what was the profit from your business over the last year? So it's their self-reported measure of profit. And we look at that in addition to sales, in addition to expenditures on assets and things like that. So
did you ask them whether they take into account time cost in that? Because it's very common for people not to take into account the value of that time when they do that.
right, essentially what we've done is we've just replicated the analysis that all these microfinance papers have done, finding that businesses are helped by getting access to microfinance or hurt by losing access to microfinance, which in general, people in the microfinance world, the practitioners, take as exactly evidence that, look, businesses are expanding, they're getting these large benefits from microfinance, microfinance works, right? And we're saying it doesn't work.
I thought the conventional wisdom was that it does not.
Well, the conventional wisdom is that it doesn't transform. The conventional wisdom is that it doesn't transform these people's lives. But the conventional wisdom is that for business owners, those businesses benefit substantially from microfinance. Anyway, you're kind of bouncing though between.
For example, like Esther, Navija, and Rachel, and Cynthia's microfinance papers.
They're the business owners. The business owners benefit. There's no impact on consumption, but the business owners benefit in this benefit.
Benefit in that they have increasing profit.
Yeah, right. They benefit in the financial sense. So I mean, the natural reaction to
there is
it.
an increase in profit that doesn't.
Right. It doesn't mean they benefit in a moment. I mean, the natural reaction is the sort of stages of denial that's happening here, and that to bounce between like, oh, it's not believable, and oh, we knew this already, right? So like somewhere in between that is kind of like
It's like welfare, or you're saying profits that don't take into account labor costs are not, like the profits and then you calculate your profits that maybe everybody is doing increases, but profits. Correct accounting. I don't know. That's
right.
That's
I mean,
point, but it's like welfare seems. I don't.
Yeah. At the end of the day, the way that I think you should think about this is sort of like people are highly price elastic to sort of microfinance. They're not willing to pay 525 rupees to keep their microfinance, right? So that just bottom line, people are not valuing. No, just give me a second. So people at the end of the day are not valuing their relationship with this microfinance organization more than 525 rupees. Now the natural reaction to that would be, well, maybe in this setting, the microfinance is not actually very useful, like we see in other settings. And so what we've done is we've replicated in our setting the results that we see in these other settings, which is that indeed the businesses themselves on paper seem to be benefiting substantially from access to microfinance. So I think it's just, you can adopt the worldview which you said at the beginning, which is that people don't know what they're doing. That can be the explanation for the data. Or it can be that people know what they're doing and they're telling us that this microfinance doesn't have a large welfare implication for them.
No, but it's in your data. Okay.
You could also just say, look, another view would have been to say, consumption doesn't go up, and therefore that's our best, typically when we measure welfare, we measure it through some consumption metric.
Yeah, but we don't. We don't measure all aspects of. Yeah, but you never measure all aspects of consumption. I mean, so yeah, so
When we try to sort of figure out who's poor and who's not poor, we typically use consumption.
yeah, so I think there were hints at this before, which is that consumption doesn't go up. But you can always counter that argument by saying, well, you care about welfare. You don't care about just consumption of like this or that. There's sort of
some expected discounted flow of consumption.
yeah, sure. I mean, there were hints at this before that people are not getting much from microfinance, but never in this way together.
Go up without consumption going up. In Morocco, we find people making a lot of money on their businesses, working much less outside, so their overall income doesn't go up, and consumption doesn't go up. They might have been tremendously happy with the whole deal because they don't have to work outside, and working outside is painful. So consumption is not welfare in that sense. Consumption is a part of welfare, and labor supply is another part. So that's all a little bit like nonsense to say, oh, there is nothing to say if you don't, since everything was said in, or is said here as well, in the fact that consumption doesn't go down. Consumption is not welfare anymore than profit. Because consumption is consumption.
Yeah, I think there are always ways to sort of squirm around it until you get something just basically on just pure revealed preference. These people don't value their relationship with the microfinance organization. And that was the whole presumption behind why you could use these microfinance relationships and leverage them to distribute all these other things that they don't want, right? And so, yeah, so we're basically just showing that basic presumption is not true, that there's not some huge surplus that people are getting from this relationship you can leverage elsewhere.
So the thing about the elasticity is one. It's not like it's like an elasticity of 5, or like it's not. I mean, it's not like everybody's got it.
I mean, there's the elasticity point, but there's also the 20,000 to 500 point, which is that's the sort of big difference, I think.
That's the difference. That profits are not measured well. I think your welfare point is about the real practice. 22% of people.
And that's elasticity.
Yeah, and people have showed before. I'm over time, but I think we're in the question stage. Yeah, we haven't discussed it, but all right. As Amitabh is coming up, I'll just say that like people have shown like there's one paper in particular I know with like Dean Carlin and John Zimmern that shows that people are price elastic, but are fairly price elastic with elasticities along these lines. But they're not also showing in that context that there are these sort of large on paper impacts of microfinance. So it's kind of piecing together the price elasticity with the measured impacts of finance, with all through sort of revealed preference.
Okay, thank you. And thank you for inviting me. I don't know anything about microfinance, so I'm not going to talk about the microfinance part of this paper. And the reason that there's a lens on this slide is actually two reasons for this. Which one of them is, of course, I consume this literature and what all of you produce from a distance. I study American healthcare. And the camera paper has had like huge implications. It comes up all the time when we're talking about instituting similar policies in American hospitals. And so whenever I think about a paper written by Esther and Abhijit, I start to think about cameras, which is probably very unfair. But the other reason will become evident towards the end of the paper. Okay, so let me just summarize what I think happened in this paper. So in terms of the treatment is that we bundled health insurance with loan renewal. The implicit premium went up by about 6 percentage points on a baseline of about 24%. So this is a pretty big increase in my view in terms of what's happening to the interest. Village level randomization, there was a rollout. The study duration is about 2 years. Okay, so what we're going to study is what does this treatment do to a bunch of different outcomes? So here's what I thought was really interesting. The first point was the point that Rick emphasized, which is that people really don't like this treatment. About 30% less likely to renew their loan in the treated villages, which was really surprising to me, given that these are people who have sort of partaken in all the benefits of microfinance. Very different than saying, gee, a bunch of people who've never participated in microfinance are unwilling to participate in microfinance. These are people who've seen that increase in profits, and they're sort of walking away from it. The second point, which was not sort of discussed in the presentation, but I thought was really interesting, was if you unbundle the health insurance that was bundled with the loan renewal, this distaste from participating in microfinance seems to be hysteretic. So, even after you unbundle the health insurance from the microfinance, you get about a 30% less lower probability of having a loan even after you've discontinued it. And I think that there's something really interesting with this hysteretic effect, because what that is telling me is, look, it's not enough that people just didn't want to pay this extra 6 percentage point increase in the interest rate. Even when you sort of take this away from them, they're like, I don't want this product. Right? I don't want the MFI loan. I don't want to renew the MFI loan, which I think that's actually, I thought, one of the most interesting things in the paper is that even when we do the uncoupling. So my first story was, they're just substituting towards loans from other lenders, and it turns out that's not the case. And it also, I thought, well, maybe it's the case that these are just a bunch of guys who can self-insure, and they're just pulling out completely. They're like, basically, these MFI loans were not being used to buy tractors or buy generators. They were basically helping me, with a whole bunch of problems I was having just kind of managing my finances. They were trying to make me more attentive and things like that. Once you charge me these 500 rupees, I'm like, well, I'll just figure out how to do this. It turns out that richer people are not more likely to be non-renewers. And then the point of the discussion that we've all been having is trying to make some sense of what it means to have these big declines in sales and profits when someone chooses not to participate in the MFI loan renewal. Okay, so I'm a health economist, so I want to talk about the health insurance part of it, which is you see these big increases in health insurance coverage. So it varies based on whether you're talking to people or talking to the insurer, but you see health insurance coverage rates jump from about 0% in administrative data to about 85%. And it doesn't look like there's any moral hazard. It doesn't look like, as Rick showed, hospitalization rates go up or health events go up or healthcare spending goes up. Okay. So what do we do about this particular interpretation? So one fact that I thought was really interesting was that when the person offering the loans tried to do the bundling, originally it wasn't offered to people who were just having their loan renewed. It was actually proposed to all clients. So even people who had a current loan, which was not up for renewal, they were being told, hey, we're now going to start to bundle health insurance. And the word that the authors used was that there was a client rebellion. Like basically, people were like, absolutely not. Don't bundle health insurance with my loan. And I think there's something to this. It's a sign that basically people don't want this particular form of bundling. But to your point, Iqbal, I don't know if that's a statement about bundling or just a point about I don't want my health insurance bundled with my loan to run my business. So why might this happen? So one story that comes up again and again, at least in the US, is that one reason is that the health insurance is not particularly valuable. And it's not valuable because what it does is it gives me access to a bunch of low quality private hospitals. So if you're thinking about India, maybe it's the case that the public hospitals, despite having long lines and things like that, actually have more competent doctors, actually are better staffed than the low quality, completely unregulated private hospitals. And it turns out the health insurance offering here actually provides access to those private hospitals. And people are like, I don't want this coverage to low-quality private hospitals. It's completely not valuable to me. It could also be the case that the hospitals are fine, but it's incomplete coverage. A lot of the Indian hospitals that I visit from time to time can admit you, but they just don't have the supplies that you might need if you had to go in under the knife. So they'll tell you, the patient, you need to go buy blood outside, or you need to buy the tube outside, or we don't have a catheter, you can buy it outside the hospital. And so effectively, it's not insurance. The third reason is that it's really not what the insurer was claiming it was, that it's not actuarially fair. So if you think about the size of the premium relative to, say, per capita adult consumption in this data set, the premium looks like 4.5% of adult per capita consumption. That's actually pretty expensive health insurance. So if I'm thinking, and this is very catastrophic coverage, right? This is just coverage for things like hospitalizations. It's not really covering cancer treatments or anything like that. It's basically insuring me if I got hit by a car and I needed to get a leg fixed, or if I had bleeding or something like that. And to spend 4.5% of income for that kind of catastrophic coverage seems kind of high to me. So it's possible that even though the insurer is saying this is actuarially fair, for this population, it's not actuarially fair at all. So I want to come back to this point that maybe it's the case that the insurance is not valuable and people know this. This is a chart that comes from US data. And I kind of wanted to push the discussion sort of away from a paper a little bit to these larger problems about insuring the uninsured in countries like India. So this is data from the US, and my guess is that it probably looks similar in a country like India. This is just a scatter plot. This is my co-author calls it the Dick Cheney go shooting scatter plot, the chaff you get. Each blue dot is an American hospital. There's 3,562 of them. These are hospitals that treat heart attack patients. On the x-axis is what these hospitals spent on heart attack patients at 1 year. On the y-axis is survival. So as you go up the y-axis, you're moving into a better and better hospital. And what you can see is a lot of health economists focus on this axis, which is, gee, look at how much we spend in some hospitals versus others. But I would say to you as an economist, who cares about the x-axis? Focus on the y-axis. Look at the tremendous implications for just human suffering. If you go to a low-quality hospital, you could have a chance of living to 1 year of 64%. If you go to a high-quality hospital, you could have a chance of surviving to 74%. So this is all using like risk-adjusted data, the best data we have, and that's one reason we can only do it for heart attacks. Now, Amy Finkelstein, Chad Syverson, Adam Scarney, and I have a paper kind of showing that patients have a pretty good sense, contrary to what is publicly believed about whether they're going to a high or low quality hospital. And so similar things might be happening in countries like India, where, again, and now I'm completely speculating, the low quality hospitals that are covered by this insurance scheme tend to be the the hospitals, which are sort of the high mortality, low survival, lousy places to be, and people just don't want that. In fact, worse than not wanting it, they associate that product with something very distasteful about the insurance, the loan itself. They say, it's a bit like saying, I get my 401k from Harvard, but if Harvard were to start to bundle the 401k with some product, that's not just a low quality product, but a truly distasteful product, I start to say things like, I just don't want to work for this employer, I don't want to participate in my 401k. So I think those are the channels that were kind of activated in my mind. And the other channel that was activated in my mind comes from work that I did with John Gruber and Robert McKnight, that at least in American health insurance markets, there's a lot of evidence, this is data from Massachusetts, that the people who participate in insurance markets know a fair bit about their health and their health risk. And so in Massachusetts, at least, if you look at who enrolled and who bought coverage, December 2007, you see this spike in the number of non-chronically ill patients purchasing health insurance. That's when the individual mandate kicks in Massachusetts. And you can see the non-chronically sick people waited till the very end to buy their health insurance. So this is another way of saying that perhaps it could be the case that the people who are kind of not participating in this product are people who say, look, I'm actually pretty healthy, and so relative to how healthy I am or what I think the expected risk of my future healthcare is, that 500 rupees is absolutely not worth it. I'm not willing to give up 4.5% of consumption for a product that I'm really not going to use. So those are the two big channels that I had in mind. So let me just kind of move on. We've already talked about this business about the utility from non-renewal being greater than the utility from renewal. And I'd like us to kind of come back to the fact that what makes this interesting to me is that it doesn't explain that hysteretic effect. It doesn't explain that reason that, the fact that even when you decouple health insurance from the loan, people still don't come back to participating in MFI. So something else happened over here. So my takeaway was that Indians like to drink tea, and they're sort of like the first tea partiers. There's something inherently distasteful about compulsorily bundling health insurance or forcing people to buy health insurance. But let me just end with a completely different piece where I'd love to see this project go in addition to where it's going, which is, in all the other work that I know of, and my sense is that I don't know a lot of the work that you guys do, but I read books like the wonderful book by Hartman and Boyce on acquired violence. Abhijit told me about this book many years ago. And this book left a big impact on me because in addition to kind of its narrative around poverty traps and things like that, it taught me a lot about just the value of catastrophic coverage for a variety of different things, healthcare in particular. And so with the fabulous data that you have, right? If you think about all the data that you have on household consumption and expenses, all the individual level data, all the data you have on health events and hospitalizations, you have 25,000 major health events spread across 7,000 households in a 15-month period. Telling the story of the insurance expansion in a country like India could actually just simply not proving, you don't have the rollout, you're just saying, look, here would be the value of catastrophic coverage in India, and then making that case would be incredibly powerful because people like me don't have data like this that really kind of tells us how often these catastrophic events happen to people. So I'm going to pause and let you guys continue to discuss microfinance.
We have just 1 minute.
We can collect some questions.
Abhijit was trying to say, we have 1 minute, that means we don't have time for questions. Abhijit was trying to say something earlier, so maybe he can use the minute.
I was just maybe responding to, it seems to me that you could read this data in two possible ways. One is that the reason why income doesn't change is because everything except what we have is mismeasured. I don't think we are saying that at all. I think we are saying, look, imagine that it's costless for people to substitute for 20,000 rupees of profits. Then the value of microcredit as an institution that provides the access to 20,000 rupees of profits is zero. If 20,000 rupees, or whatever, the 525 rupees. If you give me 525 rupees, I'll be willing to. I can find that's the marginal difference in the cost to me of generating 20,000 rupees. I imagine I take believe exactly the conclusion that consumption and income don't change. That means I substituted 20,000 rupees through doing something else, and that cost me at most 525 rupees more. So it's saying something about the marginal product of, or the relative marginal product of money. I mean, what the value of capital is. So the value of capital has to be very small. Even imagine I took the consumption data seriously, it's saying exactly the same thing. So it's not that it's giving a different message if I look at consumption. It's saying exactly the same thing, which is saying that I can somehow substitute for 20,000 rupees by doing something which doesn't take me, don't need a loan for that. So the loan is giving me at most 525 rupees more. So that's, I think as long as we take revealed preference seriously, then all these interpretations will come down to the same place. I don't think there's a second interpretation possible. I think that's, then there is the question of whether I take revealed preference seriously or not. And I think the welfare, all the welfare effects are this also, these people are not less unhappy, less happy. I mean, if they were really disappointed, you would think it show up somewhere. And they're not less happy, they're not less, they're not complaining more. They seem to be basically back where they were, except for the fact that they seem to think they are sicker than they used to be.
And that's consistent with Amitabh's point about people don't come back, even after they don't have to purchase the insurance. They don't come back because there's no real gain for them to coming back. Any sort of small fixed cost of restarting their business or ramping up, not restarting, but ramping up their business again, like any sort of small cost associated with that, there's no reason for them to come back. That's why there's this hysteretic effect.
Thank you very much.